Good morning. Before we continue on the exemplars we have today, we're still talking about what? Mobility. So let's recap what we did last week. What exemplars did we discuss last week? Osteoarthritis. What else? And what else? Okay. Tell me what you remember. Let's start off with herniated disc. What did you remember from last week? L4, L5. Let's look at it in terms of the signs and symptoms that the patient will have and what their intervention.
Back pain.
Okay, back pain.
You're going to have them stoop, bend correctly to pick up a ball.
Okay, proper what? Body mechanics. Yeah. Proper body mechanics to prevent back pain. What else? Weight control to prevent back pain and joint pains. What else? Heat and cold rotation to relieve pain. Alternate heat with cold to relieve pain. What else? If they have laminectomy surgery, they have to lay down flat. It may not necessarily be 24 hours, but for a couple of hours. Why? Keep the alignment right. Correct. To maintain alignment. What else? You have to assess the wound site. Why is it important to assess the wound site? Because if it's clear fluid, it might be what? Cerebrospinal fluid. And what will you do when you find? Call the doctor. What else? You have to log roll them. Why do we log roll? It's all about alignment, right? All about keeping the back straight. Log roll, you turn the patient upper and lower extremity as a unit, right? Okay, osteoarthritis. What do we remember from last week?
It affects most of the knees and the joints, and the patient's going to pain all those areas.
It affects mostly the joints. It's a degenerative joint disease. What else? Non-weight bearing exercise for what kind of patient? Osteoarthritis, even though your book says mild walk. What else? Swimming becomes important for what kind of patient? Osteoarthritis. What else? It is from overuse of the joint, degenerative joint disease, overuse of the joint. So it catches up with you with age or overuse, depending. It could be sports related or occupation related. Osteoporosis, what do we know about that? It affects mostly Caucasian women. Okay. What else? Let's talk about patient. Take calcium. 1,000 to 1,200 milligrams a day. Why do they need calcium? To strengthen the bones, because it's lack of calcium. The bone is being broken down faster than it's being produced. You do need that calcium to replenish that loss of calcium. They have diet low in calcium, so we need to educate them on the diet, increase in calcium. Any other thing somebody needs to add?
Vitamin D.
Vitamin D, very important also, because she said estrogen can cause that. So some of the factors, decrease in estrogen can contribute to osteoporosis. Increased phosphorus can cause that too, which you get from diet drinks. Again, they have low calcium. So anytime you have increased phosphate, it's going to replace calcium. So you don't want to increase your phosphate drinks because it's going to replenish the calcium you have. They alternate each other. When one is high, the other one is low. Any other thing anybody needs to add? It is a metabolic problem. Weight bearing exercise, walking, osteoporosis. Okay, that's good. We have to remember these things. I'm so glad you all remember. So what exemplar do we have today? MS and what? ALS. Before we continue, let's look at this musculoskeletal. The reason why we have to look at that is everything we are discussing in mobility centers in this paper. All the complications of immobility, regardless of whether they have back pain, osteoporosis, osteoarthritis, ALS, or MS, they are high risk for developing this complication. Thrombus formation. Patient that lays in the bed that's not moving is high risk for thrombus formation. So what do we do about that? What is our nursing intervention? SCDs, what else? Tate hose, what else? Get them up and ambulate. We already discussed all this, so I'm just kind of testing you to make sure we remember this. We already discussed every single thing here. So what else do we need to do? What kind of medication do you always give in the hospital every day to prevent that? Heparin. What else? Lovenox. Very good. So elimination, fluid and electrolyte imbalance. Patients that's immobile in the bed have high risk for constipation. So what will you do for them? What is your nursing intervention? You have identified the problem. When you look at the layers of clinical judgment, you have recognized the cue, analyzed the cue, prioritize their hypothesis. They have elimination problem. So what are your intervention that you can do for them? Prioritize what you have in your mind to correct this elimination problem. Hydration. Give them fluid, right? PO fluid.
Fiber.
High fiber diet, fruits and vegetables. What about the medication? Which one did we discuss? Stool softener. The most common one, almost everybody gets, Colex. So, everything we do in the hospital have a reason for that. Every medication the doctors give the patient have a reason for that. Risk of atelectasis. What is atelectasis? Collapse lung. Every patient, regardless of the disease process, regardless of the diagnosis that is in the hospital, that's laying in the bed, have a risk for atelectasis. So what is your nursing intervention? Priority nursing intervention. What's the first thing you do? Incentive spirometer, cough and deep breathe. Incentive spirometer forces them to take a deep breath and open up those airways. Again, those patients have integumentary compromise. What does that mean? Skin breakdown. So what do we do? What is your nursing intervention? Turn the patient. How often? Every 2 hours. It's not enough to say, oh, turn the patient frequently. The word frequently does not apply here because you have to have a number. Have to be objective. Remember we talked about objective data. It's something that's objective. Have to put a number to it. So every 2 hours. Bone loss. When a patient is immobile in the bed, they're going to start having bone loss. Remember when you ambulate, you're building up bones. You're building up bones as you ambulate, increasing that absorption of calcium, increasing perfusion in the body. So when they are in the bed, they can start losing their muscle and the bone, which is high risk for fall and high risk for breakdown. So we need to educate them. We need to get them up moving. If it's a patient that will never move, then active and passive range of motion in the bed becomes appropriate. Loss of muscle endurance, the same thing. If they haven't been ambulating, if you don't use it, you do what? You lose it. They haven't been using their muscles, they need to get up and start moving. Incorporate physical therapists to help you do those things. You're not going to be able to do everything by yourself. Then if they cannot move at all, active range of motion, passive range of motion becomes important. Emotional status. Those patients, you have to realize that the patient that comes in the hospital, some of them are the primary breadwinner of their family. And most of these people, if they don't work, they don't get paid. These things worries them. You cannot tell them not to worry about it. Just like you students, a lot of things worry you. Yesterday in the class, team 4, there's one particular student that comes to class 30 minutes into the class. So I noticed that. So during break, I went to her and said, I have noticed that you come to class 30 minutes late all the time. What is going on with you? She said, I'm a single mother. She looks like she's 20. I'm a single mother. I have 4 children. The first one is 11 years old. The daddy was shot. The other one is 9. It's a different dad. The other 2 is a different dad. 3 different dads. This is not a joke. This was just yesterday in the previous class. And the one that have a different dad takes care of the 9-year-old. The other 2, she has to take care of. And these other 2, she has to drop off with her mom in St. Bernard Parish. Then she lives on this side. She works at night. She get off at night, go to St. Bernard Parish, pick up the other 2 children, get them ready to bring them to school on this side of Gentilly and St. Bernard, something like that. I said, so you do this every day? She said, yes. I said, okay, let me ask you 2 questions. Do they have bus route? She said, yes, they have bus route, but by the time she gets off from work to go pick up the children, the bus already left. I said, okay. Do you know of any people that have, like, you can pay them so that I'm trying to see what's going on. To be honest with you, what I can help to do, if I have to go pick them up or whatever. Because it's very difficult. This lady is trying her best to better herself, but she has all these obstacles that she has to overcome to get to it. This is what is called determination. This is what nursing is all about. You really touched me. This is what nursing is all about. It's not about making money. I mean, money is good, but let's not forget the spiritual aspect of what puts us into nursing. She tries her best. She comes halfway. Then I told her, you know what? I recorded the class in the previous, and she was happy. Because she felt like she always misses the 30 minutes. She said when she comes in, she's going to go ask the students who came here earlier so she can get their information. Can you imagine that? Then I asked her, when do you sleep? She said when she gets out from class, she goes home and sleep, then go pick up the children again, drop them off in the morning, the cycle begins again. I cannot believe that. I said, baby, you're stronger than me. I thought, but when I had 4 jobs, I'm the most strongest person on earth. No, I don't think I can do what you do. And she's doing it with all. I'm sure a lot of you have stuff. I'm just giving one example. I'm sure there's more than one. So that's determination. That's why when student comes to school, we want you to learn. You should be able to come to school and learn something. Because you went through obstacles and so many things to get here. So it becomes important that we pay attention to emotional status of people. It's not just all about giving the patient medication. Oh, your medicine is due at 9, I'll bring it. It tickles me, it just gets to me when the nurse, patient medicine is due. Let's say the medicine is due at 11. The nurse will say, oh, you have 15 minutes. You have 15 minutes, but you're surfing the internet. When the hospital already says you can give the medicine what? 1 hour before or 1 hour after. You have 1 hour to give this medicine. The patient has 15 minutes left. Oh, you call the patient on intercom. Oh, your medicine is due at 11. You have 15 minutes. The nurse will sit right back down and surf on the internet, trying to buy different clothes or shoes or whatever. Let us not forget that emotional status. That's part of what that's really the essence of nursing. That's the essence of nursing. So always remember that this patient that's laying in the bed, they don't want to stay in the bed. They don't want to come to your hospital. They don't want to come to anybody's hospital, period. But something made them come. So we have to always remember that. My students don't understand why I said your patient better have eyes. That's my way of saying the most simplest thing we have to do for the patient, we have to make sure we can do it. That's why I don't play with eyes. Everybody in my clinical group knows that. You tell the patient, oh, you're not supposed to get up. You're not supposed to. The doctor said, don't get up. Don't do this. Don't. Okay. And they do it. They don't get up. Whatever we tell them do, they do. What are you doing as a nurse to make that patient life easier? What are you doing as a nurse to make that patient better, spiritually and emotionally? Because research shows the patient that's emotionally stable will get better faster and be discharged. So we need to pay attention to that aspect of nursing. It's not just giving them medicine. That's why patients keep getting medicine, nothing seems to work. They have some underlying things that we need to play a role. That emotional status is very important. Do not ever neglect that as a nurse. The patient needs to move. Manage my pain, then I can move. It's not enough to tell the patient, get up and ambulate. That patient is so lazy. And then not to talk about when the nurses give you a report. Oh, yeah, he doesn't want to get up in the bed. That's a lazy patient. Doesn't want to ever get up. Don't be the nurse that will go in that patient room with that attitude of the report you got. Because nurses are very good at that. Oh, that patient scream all night, call you for pain medicine all night. Well, if they're not in pain, they won't call you. They're calling you because they're in pain. If the pain medicine is not working, ask the doctor for something else. There's always something that works for the patient. We just have to find what it is. And the way you treat the patient can help them reduce their pain. If you know that this patient wants something for pain, just give it to them. Just give it to them. Simple going in the room telling the patient, oh, the nurse told me last night that your pain was very uncontrollable. I will try my best today to make sure I bring your medicine as you need it, and I will try to bring it on time. You see how this soft word, you two of you are doing the same thing, but look at how you presented that. First of all, you have acknowledged to that patient that the patient did not sleep because they have pain. For the first time, the patient is hearing somebody is listening to him or her. That nurse came in and said, oh, you didn't sleep well last night because I understand you had a lot of pain. I will try my best today to make sure that you feel better. The patient may not even call you for pain all shift. So pay attention to that. So manage their pain so they can move. Give them pain medicine, then they will be able to ambulate. Assess their oxygen status. Patients that are bedridden, stays in the bed a long time, they're going to have decreased cardiac output because there's no activity to improve that cardiac output. Anytime you have decreased cardiac output, you're going to have decreased oxygenation, but they go hand in hand. So let them get up, ambulate, increase their oxygen. Do vital sign, and then cough and deep breathe and incentive spirometer again, because they're in the bed, high risk for atelectasis, let them use the incentive spirometer. Check their vital sign, eliminate pain, anything that can cause them pain, eliminate that. So this is the general overview of priority of any patient that have mobility issue, regardless of exemplar. So let's look at the exemplar we have today. Multiple sclerosis. Does anybody know somebody who has multiple sclerosis or have taken care of a patient who have multiple sclerosis or have multiple sclerosis? Anybody? Yes. Yeah, tell us.
I have an uncle that has multiple sclerosis.
Okay.
Within, just a normal life, he has 3 children. Those are my cousins. He's much older. But yeah, we just helped him with his, we helped him with daily living activities.
You help him with daily living activities. So what's going on?
Not currently, but he passed away. But yeah, no, he had his struggles.
Okay. When you're looking at multiple sclerosis, there is what we call the nerves. Then we have what we call myelin sheaths. The nerves, just like the general nerves, controls all the movements. Then we have myelin sheaths. The myelin sheaths covers the nerves. When you have multiple sclerosis, it is an immune-mediated symptoms. What it does is the body creates antibodies. These antibodies attacks the myelin sheaths and creates some muscular problems for the patient. Because it attacks the myelin sheaths, after a while, this area becomes inflamed and becomes necrotic. And because it becomes inflamed and necrotic, it affects the nerve conductibility activities. The nerves connect to the rest of the body. Because of demyelation or attack of the myelin sheaths, it causes the nerves' conductive pathways to be disrupted. The nerves controls from the head all the way to the legs, controls our movement, control your coughing, your eating, everything we do. But because of this demyelation of the myelin sheaths, it makes that area, the conductivity of the nerve system, interrupted. So it affects the muscles, it affects the way the patient thinks, it affects emotional status of the patient, it affects basically everything that patient does is affected. Because everything we do is autonomous. You don't even know you're doing it. You're walking, I'm walking now, and I don't even know I'm walking. I'm putting one leg in front of the other because everything is working. When I have that demyelation of the myelin sheath, it disrupts that. I won't be able to walk well anymore. I won't be able to be talking normally anymore. I will have problem with speech. You have like, I won't be able to articulate my word, dysarthria. I won't be able to even know what I'm saying. I won't be able to think clearly. It affects your thinking capability. It affects the way you see. You start having a nystagmus. What is nystagmus? Or nystagmus? Rapid eye movement, right? You start having even diplopia, double vision. So it affects the whole body because of this demyelation of the myelin sheath. Because the myelin sheath is what protects the nerves. Now the protection is lost because of that damage or because your antibodies are attacking it. Because the antibodies are attacking it, then the nerves are exposed. It messes the nerves up. They're no more connected. Everything you do now is disjointed. Every activity of the daily living, everything that you take for granted becomes a struggle. Seeing problem, difficulty with swallowing, difficulty with coordination and walking, difficulty with reasoning. That's multiple sclerosis. He has a period of remission and period of exacerbation. Did your uncle have that? Period that he gets worse and period that they feel like nothing is going on with them. Do you know what exacerbates it for him? No, he probably was young. Okay. So they have period of exacerbation and period of relapsing. A period that everything seems to be remission. I'm looking. Period of remission and exacerbation. They can be triggered with cold. The trigger can be cold season or it could be hot. So these are the patients you need to protect from extreme temperatures because it can trigger their exacerbation. And when they have exacerbation, it affects their neuromuscular status. They may not be able to walk. It affects the way they reason. It affects the way they talk. They will have difficulty talking. Dysarthria, they have difficulty articulating words. Dysphagia, they have difficulty swallowing as the disease progresses. So all the functions of the body are affected with multiple sclerosis. And these people are young. They are in the middle age, like in the 40s, very young. This is the prime time you should have a good job. You're working in your field. All of a sudden, you have this disease that affects your thinking ability. Because it affects their thinking, they tend to lose their jobs because now they cannot function anymore. They are no more effective in their jobs. Of course, if you're not effective, you're not producing, you might be the best person on that job. If you cannot perform, they will let you go. So it affects their thinking, affects them job, then emotional. Because now this is somebody who have a job, maybe the breadwinner of the family. Can you imagine this happening to the lady I talked to you yesterday? You're talking about 4 children. that will be stranded, floating out there on the mercy of the government or somebody. I don't know what the government does these days anyway, so let's not even go there. But this is just the type of thing that we have to watch for patients when we're taking care of this patient. We have to understand the disease process to be able to know what they need. Okay. From this side here, tell me what you have learned so far. These 1, 2, 3 lines. Anything you have learned so far. You have to speak up so other people can hear you.
The triggers of an exacerbation
Mm-hmm.
can be like the climate, extreme climate, like
Mm-hmm.
extreme weather.
The trigger for exacerbation can be extreme climate, she said. Well, extreme weather, extreme cold, or extreme heat, or extreme cold. What else? It affects middle age. Anytime I ask you a question, let's talk about patient signs and symptoms. Yeah. It affects swallowing. Now we're talking. Yes, dysphagia, difficulty swallowing. It's going to affect their swallowing. If it affects their swallowing, what is your nursing precaution and measure? Anybody? High risk for aspiration. So what do we do about that? Elevate the head of the bed up. What else? Thicken liquid. Huh? She says suction. Well, suction standby. Okay. Other soft mechanical food. Make sure that when the patient finish eating, they still stay sitting up, right? So raise that head of the bed up. How many degrees? Huh? She said 35. Is 35 enough for somebody who is aspirating? No. Have to be at least 90. I would say 90. I'm going to sit that patient up. This is old stuff. I'm going to sit that patient way up and let the patient sit up when they finish eating. Watch that the patient is not pocketing. What is pocketing? Keeping the food in their cheek. Make sure they're swallowing. Align the body, make sure they're swallowing. So this is the patient that sit up to eat. When they finish eating, still sitting up for at least an hour. You want that food to digest before you lay them down, because you don't want them to still aspirate. So aspiration becomes an important thing. Airways becomes important. They're going to be on bed rest most of the time, because if they're having these muscle weaknesses, chances are they're not going to be hopping up and down. So they become high risk for developing atelectasis, right? Airways becomes very important. We watch that. Educate them with what? Incentives, spirometer, cough, and deep breathing. What about their movement? They're going to have ataxia, difficulty walking, coordinating themselves. So what are they high risk for? Falls. What is their intervention? Help them ambulate. What else do you need to do? If you could, put them next to the nurse's station. Put the bed alarm on. Put them next to the nurse's station. Call light within reach. Make sure there's nothing they can trap on. Right? Okay. Lord, I miss. Yes. Make sure they have a gate belt when you're trying to help them. It's correct. So let's look at this next paper. That's not it. Let's look at this paper. Did everybody pick up one? I thought I made a copy of this. If you don't, go get one over there. We have to go over that because we're going to be in groups.
I think you have tabs open on top.
There was an actress recently diagnosed with MS in person.
Selma Blair. Selma
Yeah,
Blair.
I watched the interview.
Selma Blair.
No, this is medication. This is that. It's not up there. I'm going to put it up.
Yeah.
We're going to divide up into 2 different groups. From here to here, you will do everything on the right side of the patient, the picture on the right. From here, there, you do what is the picture on the left. What you're going to do, pair up like in a small of 5 teams. Divide it up. Find the intervention to these signs and symptoms the patient have that affect different parts of the body. find the adenosine intervention for each and every one of those. So pair up in a group of 5. This side we do the right side. This side we do the left. Do we understand this? Mm-hmm. Okay, we have 15-20 minutes to do that. Okay, the question is the multi-system effect of multiple sclerosis. I divided this picture in half. This is from our textbook, page 938 from the textbook. I just made a copy of the patient that they drew with all the parts of the body that have multiple sclerosis have effect on. That's page 938 of your book. So one of them is respiratory. So which side did the respiratory? Okay, tell us, first of all, tell us the problem the patient have, the impact multiple sclerosis have on the patient, and the nursing intervention that you're going to implement for that particular diagnosis. Respiratory.
Diminished cough reflex, doing some spirometer,
Okay.
turn cough and deep breathe.
Okay. For diminished cough reflex, for respiratory, she said cough and deep breathe and use incentive spirometer. Yes, that's what you do. You need to turn the patient from side to side, cough, educate them on cough and deep breathe, and the use of incentive spirometer. If you don't do that, they're going to have potential complication. They might even have infection, right? If they keep having atelectasis, collapsed lung, they might end up developing pneumonia, mostly bacterial pneumonia. So you need to educate them to use the incentive spirometer, cough and deep breathe so they can clear their airways. You don't have that sputum staying in this respiratory tract to increase their susceptibility for catching infection. Okay, the next multiple sclerosis, multi-system effect of multiple sclerosis is the urinary. So which group did urinary? Okay. This side, somebody else on this side. Urinary. So tell us the impact of that and your nursing intervention. The signs and symptoms the patient might have and nursing intervention.
For recurring UTIs, I put increased fluid, referring from catheterization, as little as possible catheterization, and give medication as necessary.
Okay. She said for current UTI, increase fluid. You have to increase fluid to avoid UTI. The patient is going to have urinary hesitancy. What is hesitancy? What is the hesitancy? What does that mean? They cannot initiate the flow. When you're hesitant to do something, it means that you want to do it, but it's not working. So they cannot initiate the flow. So they're going to have urinary hesitancy. What do you think your intervention will be for that? Patient feel like they need to pee, but they cannot initiate the pee. What will you need to do? Huh? She said turn the water on the faucet. Well, you can do that, but I'm not sure if it's scientifically proven, but it works for some patients. Educate the patient on what we call bladder training. Bladder train the patient. That means every 2 hours, if it's a male, give them urinal. Let them attempt to void. If it's a female, get them out of the bed, sit them in the bedside commode or in the regular commode, and let them attempt to pee. So that can help with that. So for urinary hesitancy, frequency, we can do that. It's all about tweaking the brain to do the right thing we want the brain to do. If you keep bladder training that patient, offering the patient urinal every 2 hours to attempt to pee, eventually the brain is going to be wired to say, look, I need to start peeing. If everything else helps, and that patient starts having urinary retention, what do you think you need to do? Bladder scan the patient. When you bladder scan the patient, what does bladder scan do? What is the essence of bladder scanning?
It's an estimate of how much urine is left in the bladder.
To estimate how much urine that you have in the bladder. So when you bladder scan the patient, it gives you the quantity of urine the patient has. If let's say that patient have like 1,000 urine, do we continue to bladder train the patient What do you think we need to do? We need to do in and out cat. Always remember, when you have that large quantity of urine sitting in the bladder, that's high risk for urinary what? Tract infection. That can even progress to where patient can have kidney problems, where the patient can even have kidney failure from that. So we need to do in and out cat to drain the urine out. Those patients are going to have bladder problems again because of that neuro damage from multiple sclerosis. Because of that demyelination of the myelin sheath, it's going to affect how the bladder is controlled. They can either have flaccid bladder where it's too relaxed and the bladder fills up. They don't even know it fills up. And again, they're going to have a lot of spasms. Those spasms is going to, sometimes they have bladder spasms. Those spasms, again, might make them dribbling urine here and there, but that doesn't mean they're completely emptying. We still have to do bladder scan to see how much urine they have or don't have. Okay, what about gastrointestinal? How does multiple sclerosis affect the GI? The same group? And what can you do about it? What about back here? How does MS affect GI and what can you do about it? Okay. Always tell us how it affects it first. Let us know the problem, the signs and symptoms that it can cause the patient before we intervene. We have to learn it like that. Let's see the problem first, because it is the problem that you need to intervene, right? So we have to know what the problem is. How does multiple sclerosis affect the GI? We have to know that first before we know how to intervene. It's kind of like a test question. You have to know what the test question is asking you before you know you have to pick up the answer. The test question becomes the patient problem. The answer you pick becomes your intervention. So what is the GI? How does it affect GI? You have it in your paper. That's part of the things you're supposed to do as a group. So tell us. Okay. It affects the GI by difficulty chewing and difficulty swallowing. Because of that damage to the nerves that control the chewing, damage to the nerve that controls swallowing. So what will you do about it? What is your nursing? Now we know what the problem is. What is your nursing intervention? Soft food, liquid diet, sit the patient up when you feed the patient, assess respiratory status. Why do we need to assess respiratory status? Because of high risk for what? Aspiration. If they're having difficulty swallowing, chances are they're going to be high risk for aspiration. Patients that have difficulty swallowing is going to have difficulty talking. Talking and swallowing kind of go hand in hand. If a patient cannot talk, they're going to have problems swallowing. So those patients, you have to watch them closely for high risk for aspiration. Airways becomes very important when they cannot swallow. When they're having dysphagia, we need to watch that closely. Very good. What about musculoskeletal? How does multiple sclerosis affect the musculoskeletal of patient? Again, the same right side of the class. That's one of the things you all need to do as a group. Anybody who haven't said anything? Again, let's go with the problem first. How does it affect the patient before we can know how to intervene? If we don't know what the problem is, we're not going to know how to intervene, right? Okay. So what is it? What is ataxia? Anybody? Difficulty coordinating. Ataxia. Okay. So what is the intervention? Now she have listed it. How does it affect the muscular? They are fatigued, they have difficulty moving, ataxia, intentional tremors. They're going to have a lot of spasms, spasticity. It's going to interfere their movement. So what will you do about that? What is your nursing intervention for a patient who have difficulty coordinating, have spasms? Assistive devices. Collaborate with, which people do you think they need to collaborate with? PT, OT, and even speech for GI. But for musculoskeletal, they need to collaborate with physical therapists. Physical therapists are trained to help those patients that have tremors. Safety becomes important Make sure there's nothing the patient can trip on. When they are shaking like that, it becomes difficult for them to even hold spoon to eat food. So these are the type of patient that we make them eat something they have to hold in their hand to eat, like carrot. Finger foods becomes easy for them to handle. Because when the hand is shaking, they can't even hold the spoon, not to talk about scooping the food. They're having spasms all through. And they still need nutrients to be able to survive. Okay, very good. We finished with the right side. What about the left side? How does multiple sclerosis affect neurologic aspect of patient? So tell us how it affects it first, and then we look at the intervention. I'm sure you all can read.
Affects the neurological status of the patient.
Mm-hmm. How?
Again, emotional, fearful, agency, scanning,
It affects them. They are irritable. Why do you think they are irritable?
Because they're trying to do something and they can't.
They're trying to do something they cannot do. These are middle-aged patients. They are used to doing something for themselves. All of a sudden they can. It's very, very frustrating. So they're having tremors. They are scanning speech. What does scanning speech mean? What is to scan something? Yeah. It's kind of like can't choose a word. Last week in the hospital, we have a patient in room 7217, look like a 40-something-year-old lady. In this case, she has stroke. Remember, again, it's a neurological problem anyway. She has stroke. She was trying to tell us that her sister works here at Tulane. It took her almost 10 minutes. When she saw me with the student, my sister, and she can come out. The speech therapist was sitting at the bed helping her to eat. My sister, and then, walks. She kept doing this. We're like, okay, it's okay, it's okay. Here. And then she's trying to say where. First floor. Then we started listing everything on the first floor. She kept saying, no, no, no. When I said central processing, you need to see that face glow. Yes! She screamed, yes! That is scanning speech. She knows what to say. She wants to say it. It just can't come out when she needs a particular word to come out. So what is the nursing intervention for those kind of patients? Will you scream at them? What is? Take their time. Have patience with them. Give them board if they need to write it down. Some of them might write better than they talk. Give them paper, let them write it down. Give them boards, eraser board, so they can write what they mean down. It's so frustrating when you're trying to get your word across and nobody knows what you're trying to say. Something as simple as my sister works on the first floor in central processing took 10 minutes. But we want her to keep attempting to talk. It's all about tweaking the brain. The more you allow the patient to keep talking, you're sending a message to the brain, telling the brain, I still want to be able to talk. If you cease doing that, well, then the brain will shut off. Brain will be like, oh, this is one less thing I have to worry about, and shuts completely off. So it becomes important we encourage them to keep talking. Give them time to talk. Don't interrupt them. Don't hurry them. Let them do that. It's also good for their well-being. When you understand that, you need to see that joy. Yes! We are right here. But she shouted that yes, as if she was talking to somebody. But that's that joy that she was able to send her message across, and somebody was able to understand what she's saying. We take all these things for granted. We take it for granted, but don't take it for granted. So what about sensory? Sensory. This side, the right side, the left side. The group that did the left side of the body. So sensory is affected. So what are those signs and symptoms that a patient will have, and what can we do about it? Talk loud so they can hear you.
They have a visual problem, like double vision, blurred vision, eye pain.
Okay, they're gonna have blood vision. What is diplopia? Double vision. They're gonna have double vision. They're gonna have nystagmus, eye twitching. So what do you think you need to do about that? They have blood vision. What are they high risk for when they're having all these vision problems? Falls. Therefore, again, safety becomes important. It becomes important that this is not a patient you will set the breakfast tray with hot tea or hot coffee on the table. They're not going to be able to see it, first of all. And when they see it, it's high risk for them burning themselves. So it becomes important that we watch that. It becomes important that we make sure that those patients, put things strategically where they can see. This is the patient, when you set their food, they need to be able to see the food. Don't just open up the food and leave and assume that they got it. You have to be able to walk them through. This is your spoon, this is your food, it's on the left side. Find out which side that the patient can see better. Whichever side they can see better, move that food to that side. That's the only way they can see it. So these things do take time, and it takes knowledge that we are aware of all this. Otherwise, the patient is not going to be able to get their nutrients that they need. Okay, so what about reproductive? So what did they come up with reproductive?
We were planning on that, our group, teaching them.
First of all, how does multiple sclerosis affect reproductive system? What is the signs and symptoms? What does it do to the patient before we can intervene? We have to know what the problem is. We're not psychic, right? One thing nurses are not is psychic. We have to know what's going on with you to be able to intervene. Okay, it causes impotence. Multiple sclerosis can cause impotence. It can also cause infertility in women. So what can you do about that? What do you think you can do for a patient who is impotent? Is there anything that can be done about it? Yes, you can. Death is the only thing you can do nothing about. There are so many things you can do.
You can make sure they're aware of it early. That way they may be able to bank their eggs or sperm for future.
Make sure that they are aware of it. Some people can bank their sperm. The women can save their ovaries, can store those things so they can use it. If nothing else fails, educate them about adoption if they are interested in having children. We don't have to assume that they want to have children. If they're interested in having children, do that. There are surgical procedures that the doctor can perform for that too. There are medications. They have to be aware of these things. If they're not aware, it's going to worry the hell out of them. They think that that's a doom. There's nothing else they can do about it. So educate, educate, educate. Take 10 minutes break and come back. Again, continuing on multiple sclerosis. Let's look at medication. Let's look at medication of multiple sclerosis. I gave you a copy. When you're looking at multiple sclerosis, remember, it is demyelination of the myelin sheaths. They do have a lot of inflammation from those dead tissues. Interferon, look what I got in my hand. Interferon becomes one of the medications that we give the patients. Let me lose my stuff. It is an immunomodulator. Interferon is one of those important medications. What do you think it does? What does it do? It prevents that demyelination of the myelin sheaths. That's what it does. It is a very strong medication and it's liver toxic. Because it's liver toxic, you have to monitor what? Liver function test, LFT. Also, do complete blood count, CBC. Because this medication, immunomodulator, especially Avanox, that's the one of the most common ones that's being used. It's contraindicated on patients that are pregnant. Anytime you have a patient that's still on childbearing age and you're trying to give this strong medication, what do you think is the first thing you do about that patient? What kind of test do you do?
Pregnancy test.
Urine pregnancy test, UPT. Do their urine pregnancy test just to see if they're pregnant or not. So it is contraindicated on patients that are pregnant or breastfeeding. But it is a very good medication that will help to stop that demyelination of the myelin sheath. Then we have a lot of immunomodulators. We're not going to know about all of them. Then we look at immunosuppressants. Immunosuppressant. What does immunosuppressant do? Suppress the immune system. This one here, natalizumab, is one of the most common ones that we give. You can only give that only when the immunomodulators don't work for the patient. Because it has a very strong side effect, it can affect the brain. It can attack the brain and damage the brain cells. So it is given as a last resort after the immunomodulators don't work. Then we have the corticosteroids. We already know plenty about steroids because we've been talking about steroids since the cow come home. We've been talking about it a long time. The same thing for inflammation. It helps to decrease that inflammatory responses from the attack of the myelin sheath. Because it's, again, steroid, we have to watch all those side effects. So what are the side effects we need to watch? Hyperglycemia, so you need to check their AccuCheck. What else? Immunosuppressants, so they're high risk for infection, so you need to educate them if they have cold or to avoid crowd. What else? What does it do to the electrolytes? Increase sodium retention, increase fluid retention, decrease potassium level. Because increases the fluid retention, increases blood pressure. Because increases fluid retention, it increases weight gain. The same thing we've been learning since oxygenation. So that becomes important. We have to know them. Because they're of course immobile, they need stool softener. Here goes our most common medicine. Glucosate choles, glucosate sodium, they need this stool softener. And because those patients that have multiple sclerosis have spasms, bladder spasms, that can predispose them to hesitancy or relaxation that can predispose them to urinary retention, we need to give them Ditrol. It reduces bladder spasm. Ditrol is one of those common medications we give for bladder spasm to stop that from happening or reduce the symptoms. Okay, so let's look at the slide to make sure we cover everything. Multiple sclerosis is a chronic degenerative disorder of the central nervous system. We already discussed that. We're not going to spend time looking at this when we already talked about it. The process consists of loss of the myelin. We already discussed that already. Symptoms occur intermittently. We already said that they can have period of what? Exacerbation and period of what? Remission. It occurs intermittently. It's not something that occurs all the time. They have a period when they feel better. They have a period when they go into remission. If they have the attack, they're going to have exacerbation. So avoid extreme cold and extreme heat, just like we discussed. It's a chronic progressive deterioration, of course, and then period of remission. As it goes on, it affects different parts of the body. We have discussed all this, believe it or not. Motor problems, sensory problems, cerebral problems, and emotional problems. With motor problems, they're having problem at walking, weakness and paralysis of the limbs, they're going to have ataxia, difficulty coordinating their movement. They're going to have muscle weakness. It becomes high risk for fall. This is the patient you have to monitor closely. They're going to have diplopia. What is diplopia? Double vision, scanning speech. We already went through all this, right? Spasticity of muscle. They're going to have muscle spasms. So you give them medication for that. Sensory manifestation, we've talked about numbness and tingling. Because of that demyelination of the myelin sheaths, the nerve endings kind of like get disjointed, they don't connect. It makes patients to have those numbness and tingling. Not enough electricity, not enough nerve conduction getting all the way from point A in the brain to the lower extremities. They're going to have vertigo and tinnitus. What is vertigo? Dizziness. They're going to feel like they're going to fall, ringing in the ear, decreased hearing because of that. Chronic neuropathy pain. They're going to have pain because of nerve neuropathy to lower extremities. Can cause pain. So give them pain medication. What is Littman's sign? Littman's sign is they're going to feel like electric shock goes straight to their lower extremity. They're going to feel that rush of neurotransmitter. They feel like patient described as if it's electric shock going down to my lower extremity. That's what it's called, Littman's sign. Cerebral brain, they're going to have nystagmus. We're already discussing all this. Ataxia, difficulty coordinating. Dysarthria, articulate this, difficulty articulating words. Dysphagia, phagia, swallowing. Dysphagia, difficulty swallowing. Break the words in half, put them together, it makes more sense, makes it easier to remember. Bowel and bladder dysfunction, they're going to have problem with their bladder. It's either it's flaccid. When it's flaccid, it's going to fill up with a lot of urine. Because it fills up with a lot of urine, they're not going to feel it because of nerve damage to the bladder. Increases chances for what? UTI. So we need to check that. Or they have spasm in the bladder. When they have a spasm in the bladder, that means the volume of the bladder decreases. So they're going to have less urine. They're going to have those hesitancy and urgencies. They're not going to feel them. Sexual dysfunction, we already spent time on that. Educate them on what they need to do. Refer these patients to community outreaches. America have an association of anything on earth except death. They have Multiple Sclerosis Association of America, MSAA. There is always association of anything you can think of. Refer these patients to those associations because it makes them know that they are not the only one that are having this problem. There are a lot of people out there. Theirs may not even be half the problem when they see other people. It makes patients feel better when they know that other people have the same problem that they have. Cognitive manifestation, difficulty with short-term memory. Give the patient something to write for, or write something for the patient where they can look at it several times. Give them time to express themselves. Don't rush them. Plan activity with rest in between. Give them that time to think out things that they need to do. Visual perception, they're going to have issue with visualization. Falls becomes important. Make sure that you don't have like hot water around them, something that they can spill and burn themselves. Give them food they can hold in their hand because of those spasticity and shaking. Word finding, give them enough time to express themselves. Do not stop them and do not interrupt them. Listen to them. Don't listen to respond. Listen for them to finish, then you respond. Because most people, as somebody is talking, they cut them off and respond. Let them finish up. It's frustrating for them to even come up with words. Emotional manifestation, anger, depression, and euphoria. They're going to be angry. They're not angry at you. They're just angry that they used to doing things on their own. Now they cannot. Now they're depending on somebody to do things for them. You need to acknowledge that anger and remember that the patient is not angry at you. They might be talking to you at that moment, but they're not angry at you. They are angry because of what is going on with them. You have to acknowledge that fact, explain to the patient the disease process. Usually when the patient understands what's going on with them, they feel better. But nobody takes time to explain to the patient what's going on with them. You cannot begin to imagine how many times we go in a room, we explain things to the patient will be like, if they have told me this for 5 days I've been here, nobody explained this to me. It makes them feel better. They're not in the medical field. They don't know what we do. We just come in, do, and leave. They need to know. The same way you feel like if the doctor is doing something for you, you want to know what the doctor is doing. That's the same way they feel. We have to remember these things. Corticosteroids is for inflammatory response. We already discussed all this already. Immunosuppressant therapy. Of course, if they are immunosuppressant, we have to watch for risk for infection. Infection, again, becomes one of those triggers that can make those patients have exacerbation. So cold, heat, and infection. They take all these immunosuppressants. So we need to educate them to avoid crowd. We need to educate them if they have cold, they need to take their flu shot and pneumonia vaccine. This becomes those patients that are in high-risk chronic illnesses that need to take all those preventive measures, take their flu shot every year, pneumonia vaccine every how often? Every 5 years. Just like those patients with COPD. It is a chronic illness, so they belong in that category. We already talked about interferon. You need to monitor what? What do you monitor with interferon? Immunomodulators. Eh? Liver function test, CBC, liver function test. What do you need to monitor with natalizumab? This is what do you need to monitor with that? What did I say about this medicine? Avoid what? It causes a brain injury. Therefore, that's the last resort. When any other medicine don't work for the patient, they use that. It's also contraindicated in what kind of patient? Patients that are pregnant or lactation. Other drugs, muscle relaxer, we can give them muscle relaxer. Baclofen, give them all these medicines, just like any other patient that have neuromuscular issues. Physical therapy, get them involved with physical therapy. Collaborate with all the auxiliary workers. Physical therapy for ambulation. What does speech do? Speech therapy. What are the 2 things I told you they do? Swallow and what else? And speech, right? Speech therapists. So they work with the patient with speech. They also help, they are really the ones that determines whether the patient can swallow or not. They help the patient do the swallow test, and they assess the patient to see what kind of diet that the patient can have. If the patient can swallow, whether they need to be on mechanical soft with thin liquid, or whether they need to be on thick liquid, speech therapists. Then we have the occupational therapists, work with the patient with the arms. Anything your arm can do is what occupational do. They don't fool with the legs. They do arms. Help you put your clothes on, take it off. Help you brush your teeth, comb your hair. Help you go to the bathroom, clean yourself. Help you shower, occupational therapy. Anything the hands can do is occupational therapy. Anything the legs can do is physical therapy. See how easy those things are? Easy to remember. Release spasticity. Ambulate the patient. Give them the medicine when nothing else works. Improve coordination again. Collaborate with physical therapy. I always say this. Your ability to identify who the right person to collaborate with, to me, is an intervention. If you can collaborate and know your patient needs physical therapy, call physical therapy. The patient, she comes or he comes to ambulate your patient. To me, that's an intervention. Your patient have problems swallowing, call speech therapist. Come and see this patient. He was coughing when he or she was eating. They assess the patient for you. So those patients becomes high risk for aspiration because of because of the neuro damage. So they can easily aspirate. So airways becomes important. We need to monitor for airway being compromised because of difficulty swallowing. Help patient identify triggers and stay away from the trigger. Always very easy to remember. Assess patient in dealing with anxiety. Of course, they're gonna have anxiety again because they're not moving. They're not doing what they're supposed to be doing before. It gives them anxiety. They don't know what the next level will be. They think that they're gonna die. They think that everything is crushing on them. So they need to understand what's going on with them. during exacerbation, prevent a complication of immobility. That's what we've been talking all day. Let them move around. If they cannot move, active and passive range of motion becomes important. Let the physical therapy come and raise their leg up or their arm up for them. If they can do it for themselves, let them do it. If they cannot do it, help them out. Anything is better than nothing. Turn them how often? Every 2 hours. Avoid fatigue. Do not overdo it. Don't overdo it. Let them do as much as they can do, but don't overdo it. Teach patients good balance and exercise. It's very important that they rest. Good balance. Physical therapy, again, will be able to do that for us. Your goal becomes nutrition. Make sure that your patient can eat. If they cannot eat, they're having problems swallowing, they're having a dysphagia that's more advanced, then enteral feeding becomes tube feeding, becomes an option. So tube feeding can become an option through that advanced stage when the patient cannot eat anymore. They're having problems swallowing, they can have tube feeding. TPN is not an option because TPN is more temporary. TPN is for people who can eventually might start eating, but if the patient have advanced where they cannot eat, they having severe dysphagia, they are phasic, having dysphagia, tube feeding becomes, peg tube becomes the only option. Because it's more permanent, it's not something, you cannot do NG tube. Why can't we do NG tube on those kind of patients? Nasogastric. Why can't we do NG tube? They cannot swallow. They cannot swallow. They attempted to try that last week. We have a patient that all of a sudden, their patient has been in the hospital. You all remember the patient I'm talking about, those people in my clinical group? All of a sudden, last week, the patient stopped swallowing. He cannot swallow anymore. He has been swallowing for past 4 weeks. All of a sudden, he cannot swallow. And his speech is becoming more dysarthria. I'm like, really? So the nurse say, oh, Dr. Eweni, you're going to put NG tube on the patient. I said, really? I say, I know, you know we love to do everything. But if a patient cannot swallow, you cannot do NG tube. She said, yeah, but the doctor wants it. I said, well, you do it, and we're not doing it this time, maybe next time. So 3 hours later, I asked her, have you put the tube in? Guess what she said? No, the doctor DC'd it. I already know you're going to DC it. For you to have NG tube, the patient have to cooperate with you. You have to put the eyes in the mouth, the patient have to swallow for you to advance the tube. If they cannot swallow, you cannot advance the tube. Therefore, you don't need a tube. As simple as that. When I told her that, she was like, oh. I said, no. I said, I'm going to give you the rationale. The patient cannot swallow. If they cannot swallow, they don't need NG tube. So she goes, yeah, but the doctor wants it. I said, you know what? You'll do it this time. Do it this time, another tube will come out, we'll do that one. I already know it's not going nowhere. Then that's why I went back and asked her several hours later, did you all put the tube in? She said, no. The doctors DC'd it, and they're planning on putting peg. It can't be no better than that. See, all this stuff we're learning makes sense. If they cannot, they have to be able to swallow for you to advance the tube. If they cannot swallow, then you're going to put that tube in the trachea. Trachea goes in the lung. It's not doing anybody any good. So, I'm sure if we go there this week, the patient have peg. I'll give you an update if he's still there. Avoid hazard of immobility. Let the patient get up and ambulate. Avoid those respiratory problems that they can have, or the event thrombosis. We went over all that already. Self-catheterize if necessary. If they cannot pee, we already scanned the bladder, they're returning urine a lot. We're doing in and out. You're not going to be doing in and out endlessly. After a while, you may have to put the Foley in. When it's not, you've done everything, nothing else can be done, we just put Foley in. When the patient goes home on Foley, we need to educate them on how to care for the Foley. Always remember, what kind of procedure is Foley? Sterile. Therefore, everything about Foley has to be sterile. We need to educate the patient on that because they don't know that. You need to show them how to hang the bag. Something as simple as that. If they hang it on the side rail of the bag in their home, it's going to have UTI. They need to hang it below the bladder, below them. Educate the patient on all those simple techniques that can save life, can prevent them from having infection. ALS. In your book, ALS is one sentence, 1 or 2 sentences, right there. If you go to your book, ALS is like 1 sentence or 2. Needless to say, it's not in the book. So, what is the whole meaning of ALS? What is amyotrophic? What is trophic? What does the word myotrophic means? Myo, muscle.
Yeah.
Lateral means what? Side. Sclerosis means what? Hardening. That's all it is. Amyotrophic lateral sclerosis. Hardening of the neuromuscular transmitters that makes this patient have spasms. It is a neuromuscular problem that degenerates until death. It is something that progresses. They keep having muscle weaknesses, muscle wear and tear, weaknesses until paralysis. Nothing stops it. They are going to get to death. That's ALS. Those patients that are diagnosed with ALS have 3 to 5 years to live, except one person that I know of, Steve Gleason. How many of you know Steve Gleason in New Orleans? He is the only one that I know that have ALS. I think he's been diagnosed more than 10 years now. That's what happens when you have money. That's what happens when you have money. For some reason, he collaborated with Bill Gates. Bill Gates bought him this big, or made him, the Microsoft Google, made him this screen where he can use his eyes to communicate. He uses his eyes to write, and then he'll be smiling. Then the machine will be echoing what he's writing with his eyes. So patients that have ALS have their cognition is intact. They have intact cognition. Their vision is intact, as opposed to somebody who have MS. Patients that have MS, it affects their cognition, affects their intellect, affects their vision. But when you have ALS, you have intact cognition. It is the muscle of the body that's being affected. When we're talking about muscle in the body, we're talking about respiratory muscle, we're talking about cardiac muscles, we're talking about every single muscle in the body. So those people become high risk for aspiration, they become high risk for airway being compromised, they can go into respiratory failure very easily. ALS. It is a disease that progresses to paralysis. There's nothing you can do about it. So it becomes important before the patient gets to paralysis or to the point where they cannot communicate anymore, that we get advanced directives. We need to know how to care for the patient when you get worse. So it becomes important that we have those information available. How do you want us to care for you when you cannot take care of your own self? Which everybody in the hospital do get in the emergency room, I think. Everybody gets that in the ED, but it becomes more important that we get that. So that the nurses will know how to care for the patient. Do you want DNI? Do you want do not intubate or do not do this? Whatever you want us to do needs to be done when the patient can still talk. So that when the patient cannot communicate anymore, we need to know what to do. So this patient becomes important. Respiratory failure, they die from respiratory failure because of all the muscles don't work anymore. There's no more functional muscle of the lungs. It's not expanding and contracting, expanding and exhaling, inhaling and exhaling. Most of them end up being intubated in the hospital. And when they are intubated in the hospital, that doesn't mean they will be extubated. It just means that intubation doesn't work for them. They just intubate the patient, maybe until the family says, take the patient off life support, because they are going to die. That's why most of them will choose not to be intubated, because it's not like if you intubate me, I'm going to get better. They will not. So those patients with just paralysis die from that. Remember, paralysis does not mean only muscular, like quadriplegic. Paralysis means the lungs, all muscles in the body are paralyzed. And you do need the accessory muscles to be able to breathe. If you look at Gleason, he has big trach, has big machine that breathes for him, that he uses to breathe, he breathes from. Then again, that's what money works. Big one. He carries it everywhere he goes. One of my students in this class, maybe a couple of years ago, says he's going to work for Gleason. So he has one nurse, one-on-one. Do you know how many patients in this whole United States that have MS that can afford that, afford the machine, afford the breathing machine, afford the one you communicate with, plus one nurse, one patient. And that one patient is who? Gleason. So on the average, the life expectancy for those people is 3 to 5 years, but he has surpassed that. So he's doing good. So hopefully over time, they're going to find a cure or something that can help those patients. There's one medication that riluzole is the only medication that is used for MS. Riluzole does not cure the disease. It just prolongs life. It just kind of prolongs the inevitable. It doesn't cure it. It just prolongs it. It's very important we monitor liver function tests on that. So it affects the liver also. So those patients that have ALS, airways becomes important. We need to feed them, so they need to have PEG tube. This is not the patient TPN can work for, because TPN means eventually you're going to eat and it will be discontinued. More permanent way of feeding becomes important. So PEG, no NG tube. You cannot put NG tube in their nose. First of all, he already have airway compromise because he has trach. You cannot put NG tube on somebody who have trach. Airways, mobility becomes important even though they are paralyzed in the chair. Active, passive range of motion becomes important because you don't want to completely lose the little that you have. Cognition remains intact. Vision remains intact. Just the neuromuscular part of the body. The muscle part of the body is being affected more. While in multiple sclerosis, they lose level of cognition is not intact, vision is not intact. So ALS, Lou Gehrig disease is another name for it, characterized by progressive weakness, muscle wasting that goes all the way to paralysis and eventually death. Remains cognitively intact, there's no known cure. Fasciculation, what is fasciculation? What does fasciculation mean? Rapid movement. They get cramps, tight and stiff muscle. Again, it has to do with muscle. It's tight, it's fixed, they're not using the muscle, so muscle atrophy becomes a problem. Always remember again, anytime we're talking about muscle, we're not talking about just the lower extremity and the upper, we're talking about respiratory muscles too. So respiration airways becomes important, compromise mostly on those patients that have ALS. Weakness in arms and legs, difficulty chewing or swallowing. There is no cure. Drug therapy is to treat symptoms. Riluzole becomes the only medicine, the most commonly used one. It's only to treat symptoms, it doesn't cure the disease. The goal of intervention, optimal functioning. Whatever the patient can do is the goal. They cannot get up and start jumping and walk from here to Nigeria. Any little thing they can do, help them out. Collaborative approach, physical therapy becomes important because they need to help them with passive range of motion or active as little as they can do. Speech therapy becomes important because of swallowing and speech impairment they might have from those muscle wasting. You don't want them to aspirate, they are high risk for aspiration. Occupational therapy becomes important to help them in their daily activity of daily living, to brush their teeth, comb their hair if they still can do that. Nutrition consult, again, At this point, they're not going to be able to be eating. Pig tube becomes important. Enteral feeding becomes important because they cannot swallow. They are high risk for aspiration. Respiratory therapy, of course, because they're going to be on trach. Respiratory therapy needs to help them out in suctioning and making sure that their airways are maintained. Hospice, that paralysis to death. We need to educate them on hospice. When a patient has only 6 months to live, you put them in hospice. Hospice is mostly for comfort. They are dying. Give them their morphine sulfate. Morphine is the most common medicine you use in hospice. Because it's a narcotic, it's an opioid, it's going to depress respiratory center. When a patient is using it on hospice, we don't worry about it depressing respiratory center. We don't worry about it affecting their breathing. Because they're dying, they need the medication. You need to give it to them. It's for comfort. Because they're dying, they need to die pain-free. They need to die in peace. Any questions? Any questions? Yes. Give it. If the respiratory rate is 1, give it. If it's 5, give it. You're not giving it for that. You're just giving it for comfort measure because they're dying. Good question. Oh, what?